Hello, my name is Kai Bartlett. I'm a pharmacometrician here at Allucent, and today I'm going to be talking about a poster that I presented at ASCPT 2025. The title is Model Estimated Tissue Pharmacology as a Surrogate of Monoclonal Antibody Clinical Efficacy Dose Response, and we used a case study with dupilumab in patients with atopic dermatitis. So just overall background, the development for monoclonal antibodies or mAbs for treatment of various diseases has rapidly increased in the past decade or so. They have high potency, target specificity, long half-lives, and convenient dosing regimens that make them a very effective treatment option for various diseases. But we've come to realize that there are not many published examples demonstrative the predictive value of pharmacokinetic/pharmacodynamic models to predict clinical efficacy dose response. So dupilumab or Dupixent demonstrated a clinical dose response in atopic dermatitis in a phase 2b study. And so it was because of that reason, it was selected for this case study. Just quick overview for the mechanism of action for dupilumab. It was approved for treatment for atopic dermatitis, COPD, asthma, and several other type 2 inflammatory diseases. It binds to the IL-4R alpha receptor and inhibits downstream signaling of inflammatory cytokines IL-4 and IL-13, as we see here in the schematic here in the graphic. The main question was, could a model of dupilumab PK and PD have predicted the phase 2b efficacy for treatment of atopic dermatitis? Basically, could we have used modeling and an informed model to make a decision on what the dosing regimen should be? And so to start, we assumed that the amount of drug in the skin bound to the IL-4R alpha receptor could be used as a surrogate biomarker for improvement of skin conditions. So we're targeting atopic dermatitis, so focusing on drug concentrations in the skin. So we built a minimal physiologically-based pharmacokinetic or minimal PBPK model for short to predict dupilumab concentrations in both systemic circulation and in the skin. So it started with previously published 2-compartment dupilumab model in healthy adults. Then we added a skin and lymph compartment. So then we simulated the 16-week phase 2b study using the 5 different dosing regimens in a virtual adult population, just to verify the model was predictive of the median observed dupilumab PK in plasma at any dose level. And we felt confident that our model was predictive of PK, so then we moved on to developing the PD side, the pharmacodynamic side of the model. That involved using in vitro binding affinity parameters for dupilumab binding to the receptor and estimates of the receptor density within the skin compartment. And so we extended the model to include dupilumab binding to these receptors in the skin to then predict the receptor occupancy, right? The percentage of receptors bound to drug that are no longer available to bind to the IL-4 and IL-13, those inflammatory cytokines. So we were able to predict free and drug-bound receptor concentrations within the skin based on the skin dupilumab concentrations. So now we have this final minimal PBPK PD model that predicts the skin receptor occupancy time course and exposure dose response following each 16-week multi-dose regimens from that same phase 2b study. And so now we have the predicted receptor occupancy over the 16-week dosing period. And then that I should mention before, that dashed line is the end of 16 weeks. So within that study, they used a couple different metrics to measure improvement in the condition of the skin. So we focused on looking at the observed change in the eczema area and severity index from baseline. And this was collected all through the dosing regimen, but we focused on that 16-week final change from baseline. And so to compare, those scores with our model predictions of receptor occupancy, we fit these Emax dose response models for change in those EC scores from baseline at 16 weeks versus a monthly dose. So there were 5 monthly doses ranging from 100 milligrams subcutaneously once a month, all the way up to 300 milligrams subcutaneous every week. And so we just said that those, multiply by 4, we said that was the monthly dose. Similarly, we fit Emacs models for the predicted receptor occupancy versus the monthly dose, and just compared. Just look at the curves, see what they look like. And so after doing a little bit of comparison, we also decided to consider a normalized easy score change from baseline, meaning that, say, that highest dose of 300 milligrams once weekly, we said that would elicit the most improvement from baseline. And so we scaled by that maximum change. And so that in that green line, we say that that's, 100% improvement, like relative to baseline. And so the Emacs dose response models for receptor occupancy and these eczema scores adequately describe the data. And we see that we're having a nice trend. And so we decide to just focus on the curve, the normalized normalized eczema scores versus receptor occupancy. And we see that our predicted receptor occupancy at Emacs curve was just shifted to the right when compared to the observed efficacy dose response, but a very similar shape, meaning that we can look at those last two dose levels and feel like confident that those are probably going to be the best dose levels to select. So this demonstrated that simulated dose response model would have been informative to guide dose selection in this phase 2b study for dupilumab. And further investigation with similar mAbs is warranted to see if this process can be replicated across other compounds, other monoclonal antibodies, other targets, and other disease states. Thank you for watching. If you'd like to learn more about how Allucent's clinical pharmacology solutions can support your drug development journey, connect with me on LinkedIn or visit the Allucent website.